Bismillahirrahmanirrahim. Now we'll move towards our next topic, which is local anesthesia. Now, local anesthesia is basically the induction of temporary induced loss of sensation. It consists of 2 points: analgesia, which is pain relief, and paralysis, which is muscle relaxation. Now, this type of anesthetic is given when general anesthesia is dangerous, is proven to be dangerous. That is in cardiovascular problems. If the patient is having myocardial infarction, you cannot give general anesthesia because it will be difficult for the heart to pump, because at that state a lot of muscles are in the state of relaxation. And in obstetric cases such as C-sections, it is also given in post-operative periods in order to reduce the risk of analgesics. Now, topical anesthetics are broadly categorized into two. One is eutectic mixture of local anesthetics, shortly known as EMLA, which is a mixture of lignocaine and prilocaine. And the other is Mofat solution or cocaine, which is given in nasal surgery because it has a specific effect of causing vasoconstriction. By vasoconstriction, the arteries would similarly, because the nose is supplied with a lot of blood vessels, so it has a greater tendency to bleed out. So by giving the solution, there will be decrease in the spillage of blood upon any cautery introduced. Now there are various types of local anesthesias, such as IV blocks, topical anesthesia, plexus blocks, spinal anesthesia, and epidural anesthesia. But the first local anesthesia we'll study will be spinal anesthesia. Spinal anesthesia is given to people in procedures that are done below the umbilicus level, such as C-section, prostatectomy, and even pelvic surgery. Now, the procedure of this anesthesia is that first of all 1 liter of crystalloids are given to prevent hypertension, and the patient is asked to lie in a lateral position. The back is painted with iodine or pyridine. Now the anesthesia is given below L5, L4 and L5 level because there is the spinal cord termination point, which is also known as conus medullaris. Now, after that point has been identified, we draw an imaginary line from iliac crest by putting our hands upon both of the iliac crest, and we join the thumb to a center point. When the thumb joins to a center point, it imaginarily identifies L4 and L5 level. Now we generally rub our thumb up and down into the intraspinous space. Now this is an ideal space through which a spinal anesthesia is given. We will first make our concepts better by a video. Now as you can see, the back is painted with pyridine twice. Now we clean the skin with the spirit twice. This is for an antibacterial effect, so before giving any type of anesthesia and introducing something into the body, we have to adequately clean the outer area because it is normal flora to a lot of bacteria. Now we clean the skin with a dry gauze piece. Then we feel the posterior superior iliac spine and palpate at L3, L4 and L5 space actually, where the conus medullaris terminate or spinal cord terminates. Now this is the person is feeling the intraspinous space. We mark it. Now we advance the 25 gauge spinal needle in the middle of L4 and L5. We penetrate through the skin, subcutaneous tissue, supraspinatus, intraspinatus, ligamentum flavum, epidural space, and then we enter the dura. Now we remove the stellate and look for CSF. It should be clear, fluid freely flowing through it. After we see the fluid coming out of the stellate, now we connect it with 5 cc syringe, which is loaded with 0.5% bupivacaine, and in C-section we give it approximately 2.5 ml. Now we aspirate the needle to look for free flow of the CSF, and we inject the anesthetic drug. You aspirate once again, inject it, and at last before injecting 1 ml of the drug. Now take the spinal needle and syringe out together and put a gauze piece and apply a small sterile tape at the site of injection. So again, a brief review of this procedure. So we injected a spinal needle through the skin. Now you need to remember how many layers it has penetrated to enter that spinal space area. So we cross the skin, the subcutaneous fat, the supraspinous ligament, the interspinous ligament, ligamentum flavum, epidural space. Now remember, this space is used for epidural anesthesia. By crossing this space, we entered the area in which spinal anesthesia is being induced. Now we'll discuss its various advantages as well as disadvantages. The advantages consist of that no equipment is needed, no gas is given which may cause air pollution, no loss of consciousness, simple and cheap, and it causes abdominal relaxation. The disadvantages include headache. Headache is caused because when spinal tap creates a passage for the spinal fluid to leak out and changing the fluid pressure around the brain and spinal cord, resulting in headache. Hypotension is due to blockage of the cardiac sympathetic nerve, whereas spinal cord injury can also be resulted because of the wrongly positioned needle, as well as the respiratory system can be suppressed if anesthesia is given at an upper level of L4. Now, this symptom is one of the commonest symptoms due to which many people are fearful, hence they prefer general anesthesia over spinal anesthesia, which is back pain. Back pain is caused due to multiple factors. The pathogenesis of postoperative back pain include type and duration of surgery, duration of immobilization, as well as position of the patient during the spinal puncture. The diagnosis of back pain is not simple because contributing factor may include needle trauma, surgical positioning, injections of saline or local anesthetics into the intravenous spinous ligament, and development of supraspinous hematoma, excessive stretching of ligament after relaxation of the paraspinal muscles, and localized trauma to the intervertebral disc. Its relation with various types and sizes of spinal needle is yet to be confirmed. Now, there are two types of complications by spinal anesthesia. One are the immediate and the other are late. The immediate complications include nausea, vomiting, spinal cord injury, needle breakage, paralysis of the respiratory muscle, nerve root injury, paresthesias, and hypotension. Whereas late complication includes neurological impairment, postspinal headache, meningitis, back pain, infections, disc prolapse, urinary retention, damage to the extradural vessels. Lastly, we'll discuss the contraindications. Some are absolute, whereas others are relative. The absolute contraindication for spinal anesthesia is as increased intracranial pressure because it will cause increased probability of CSF leakage. It should absolutely never be given to patient without consent. Blood diathesis, which is coagulation problems that can result in bleeding out to the puncture point, burning at the injection site, which is allergy at that some point, and systemic sepsis, whereas it can be a route or point of entry to many infections. Heart valve diseases, whereas relative contraindications include CNS disease on antiplatelets such as loprin, loplet, chronic back pain, and hypovolemia.